We hope you enjoyed our first video. It's originally from Australia and it had sound, but we had to take it out because no one could understand what they were saying. Safe place, don't worry. So we're going to see some familiar faces who made the journey to celebrate with us this evening. Snoop Dogg, great to see you. Babes, so glad you can make it. Hugh Jackman, always a pleasure. This year's festival focuses on the controversial issue of the malicious malalignment syndrome, also known as patellofemoral pain syndrome. We hope you will gather the following information from our videos. Number 1, identifying the main causes of PFPS. Number 2, identifying the treatment options for PFPS. 3, discussing the strengths and weaknesses of the various treatments for PFPS. And 4, making an educated decision on the best treatment for PFPS. For those of you watching from home, who can tell me what orthotics are and what they're for? How many of you own and use orthotics? Can you describe the way that orthotics change the biomechanics of a flat foot? Have any of you experienced anterior knee pain? Pay attention to our next video as it will show you a foots-on demonstration of how to determine differences in foot structure. Now we join Phyllis, the flat-footed pheasant farmer in the new film, The Young and the Longitudinal Archless, as she learns something that will change her life forever. Phil, Dr. Vandersizzle will see you now.
All right, well, test results are in.
Right.
And I don't know how to tell you this, but you have flat feet.
Flat feet, but the pain's in my knee.
Yeah, we'll get to that, but I mean, your knee is only a casualty, a victim in this situation for the condition that's your flat feet. So you're lucky this isn't going to kill you, but it's going to change your life.
Right.
So you do have some options.
Okay.
But before we get there, I'm going to just give you a bunch of information regarding this condition, and from there, you can make a decision on your own.
Okay.
All right?
Sure.
So, what you need to know, look right here. Okay, so here's the ankle. As you can see, there are more than a few bones that comprise your ankle and foot. So here is a posterior view of the bones that make up your ankle joint and the ligamentous tissue that connects them. Your talus articulates with both the tibia and fibula to form the ankle joint. And please note its orientation in this photo, as your foot is not nearly as beautiful. You know, in fact, there are 26 bones in your foot alone. These bones are oriented such that your foot can adapt to a wide range of different surfaces, and like all in all, your foot is a beautifully adapted structure for locomotion.
So, what is wrong with my foot, Doc?
Well, easy, Phyllis. We're getting there. Just come look at this for a second. You see the arrangement of the bones in this photo right here?
Mm-hmm.
So of the 3 arches, the medial longitudinal arch is of the greatest clinical significance, and this is where your problem resides. We have the medial longitudinal arch, which is MLA for short, because it's a tongue-twisting, crazy word. We got the calcaneus, we got the talus, navicular, and 3 cuneiform and 3 metatarsal bones that make up this structure. All right, so you see this photo here. Your arch is supported by various soft tissues, such as the plantar calcaneonavicular or spring ligament. Also, there's an aponeurosis that comprises your plantar fascia, and also tendinous tissue, like the tibialis posterior muscles. So altogether, these act to sustain your medial longitudinal arch. These ligaments are important structures in a human foot, but in the case of your foot, we can assume that they exist with a degree of hyperlaxity and allowing your arch to drop. Some people like to call this pes planus, or flat-footedness, whereas the opposite of this would be called pes cavus, or an high arch foot. So, why don't you come with me? We can do this demonstration, and you'll quickly appreciate these different foot types.
So for our participation project, what we thought would be really cool is if we got the class all to take off their shoes and socks, and what we're going to do is have everybody dip their feet in paint. And step on a piece of poster board. So this is a really nice way to illustrate the different foot types of the class, specifically comparing feet that have more arch. So there would be less paint in here because it would be a more defined arch, as opposed to somebody with flatter feet, which would have all the paint in here. And that's a really good illustration of what flat feet look like. So pretty cool and pretty fun.
Alright, so we have these three kinds of feet: pes planus, neutral, cavus, and obviously you have planus foot. Now these can be defined farther into flexible or rigid flat foot. How do we decipher that? Just take off your shoe right now and I can show you.
Alright.
So I'd like you to extend your toes. Extend backwards like that as much as you can. And you see how your MLA comes back like that? Whereas you put your foot, stand up now. Alright, so you're standing and you can see that your MLA disappears again. Where'd it go? Well, you've got a flexible flat foot, my friend. Look at that. And again, these can be classified into an asymptomatic or symptomatic foot. You have a symptomatic.
So what exactly does all this mean for my knee? I don't really understand.
Well, neither do I. I'm only a general practitioner. So I have the actual power of referral, actually. So I'm going to just send you off to the biomechanics expert, and they'll take care of you, and I'll just sit back and make my money, all right?
Well, sounds good to me.
All right, so here's the number for Dr. Morris. If you could just go see him, get back to me in about a week, reschedule another appointment, I'll see you then, all right?
Yeah, sounds good. Thanks a lot, Doc.
It's good seeing you.
Yeah, good to see you.
So I want to talk to you a bit today about your foot problem. So a normal arch acts to dissipate the forces incurred while weight bearing before they reach the long bone of the lower leg. So in normal weight bearing, forces are transmitted through the talus to the medial aspect of the foot, specifically to the talonavicular part of the transverse tarsal joint, causing pronation of the forefoot. The weight of the body drives the head of the talus downward between the calcaneus and the navicular, and this force is resisted by the spring ligament. In pes planus, the head of the talus is displaced medially and plantarward from the navicular. This displacement stretches the spring ligament and the tendon of the tibialis posterior muscle, resulting in the loss of the MLA. When viewed from the posterior aspect of the foot, the calcaneus will be everted, like so. Over time, this functional deformity will develop into a chronic structural deformity, and abnormal stresses will be transferred to more proximal areas affecting the knees, hips, and low back. Pes planus is not necessarily symptomatic. In fact, many cases of fallen arches are painless because the foot adapts by changing the shape of the bones and by stretching the ligaments. The structural changes that accompany a flat arched foot, however, affect the normal biomechanics of the lower extremity. Pronation, which is a normal component of gait, becomes exaggerated in the foot with pes planus. The lack of an arch maintains the foot in a flexible, unstable position, hindering normal gait and creating a wide variety of compensatory pronation disorders, such as patellofemoral pain syndrome. Essentially, what you're dealing with here is a manifestation of symptoms up your kinetic chain. The pain arises from the compensatory actions that occur at your knee due to this unstable orientation. Looking at this diagram, overpronation eventually leads to lateral tracking of the patella. This abnormal lateral tracking may be associated with changes in magnitude, distribution, and patterns of of patellofemoral joint contact pressures and results in this anterior knee pain you know so well. Great, so hopefully you have some more information and that you can take back to your doctor and you too can sit down and make an educated assumption on what your treatment options are. Perfect, great. Good to see you, Bill.
Next we have our third video, brought to us by world-renowned fitness enthusiast and film producer Rochelle Simons. She will be arguing the benefits of exercise as a treatment for this dreadful condition.
Is resistance training. For people with flat feet, there's a tendency for the knee to internally rotate. What you want to do to fix this problem is really strengthen your hip abductors and your external rotators. These guys are going to show you how it's done. Phyllis here is demonstrating an exercise which is strengthening her hip abductor muscles. She is slowly moving her leg out to the side, keeping her hips in line. A second exercise she can do is moving her leg backwards at a 45-degree angle, maintaining that straight pelvis. Another source of pain for people suffering from PFPS caused by flat feet is the asynchrony in the firing rates of the vastus medialis and vastus lateralis. Under normal circumstances, you want your vastus medialis to fire at the same time or before the vastus lateralis. If the vastus lateralis fires first, it will cause abnormal tracking of the patella. Frank here is demonstrating the quarter squat. This exercise establishes new neural pathways, training the vastus medialis to fire at the same time or before the vastus lateralis. After a few weeks, Frank can progress to the half squat or the full squat. Check out those quads! Two final quick points. Wearing shoes can increase the workload on your knee joint. So fellow flat feeters, be sure to incorporate barefoot walking into your day to strengthen the small muscles in your feet and decrease the load on your knees. And as always, don't forget to stretch your hips, quads, hamstrings, and IT bands.
In this year's Best Documentary category, we feature some riveting footage of the use of orthotics. Let's have a look.
A prescription foot orthosis is a custom-fit in-shoe device that is made from a custom mold of the plantar foot. Orthotics are prescribed and designed by qualified healthcare professionals to alter the magnitudes and temporal patterns of the reaction forces acting on the plantar aspect of the foot. The goal of orthotics is to allow for more normal foot and lower extremity function and to decrease pathological loading forces on the structural components of the foot and the lower extremity during weight-bearing activities. Foot orthotics have been shown to significantly decrease Q angle and to significantly decrease the magnitude of internal rotation of the leg when walking. In those with pes planus, orthotics can support the arch and prevent hyperpronation. Because excessive pronation can lead to excessive tibial and femoral internal rotation, as well as lateral patellar displacement, some investigators have suggested the use of foot orthosis for treatment of patellofemoral pain. In those with patellofemoral pain who demonstrate excessive pronation, foot orthotics may significantly improve pain, stiffness, and physical function for patients.
So today we've seen evidence for both sides of the treatment debate, but we have finally narrowed down a winner. Congratulations to Rochelle Simons and her cast! While we recognize the important contribution of orthotics in decreasing pain, they appear to be more of a band-aid rather than an effective long-term solution to PFPS. An appropriately prescribed exercise and strength training program, on the other hand, is considered more likely to affect biomechanical changes and help patients in the long term. Based on the information you have seen today, we'd like to ask you to reconsider the following questions. How does pes planus cause PFPS? What are orthotics and what are they used for? How is exercise an effective treatment for PFPS? And how would you defend the effectiveness of different treatments for PFPS?